औज़ुबिल्लाहिमिनश्शैतानिर्रजीम बिस्मिल्लाहिर्रहमानिर्रहीम अर्रहमान अल्लमल कुरान खलक़ल इंसान अल्लमहुल बयान। आज काफ़ी दिन के बाद आपसे बात हो रही है। उम्मीद है आप लोग ठीक होंगे। हमेशा से शुरू करने से पहले अहम बात, रिमेंबर टाइम इज़ मोर वैल्यूएबल देन मनी। यू कैन गेट मोर मनी बट यू कैन नॉट गेट मोर। अभी जब आपकी ट्रेनिंग चल रही है तो दिस इज़ द मोस्ट इम्पॉर्टेंट टाइम ऑफ योर लाइफ। सो आज के सिलसिले का जो टॉपिक है वो है प्रिकॉशियस प्यूबर्टी। रिमेंबर दिस इज़ अ वेरी इंपॉर्टेंट seemingly difficult case, but if you know how to proceed, inshallah you will go through it easily. So the command can be, this is a 6-year-old boy, or it can be girl, she or he can be girl, whose parents are concerned and worried about excessive facial hairs to the GPE and relevant most common presentations. So like the normal long cases or short cases you introduce and you have a consent, then hand sanitization exposure ideally should be only shots, but you have to keep in mind the modesty and the weather. Then to you talk to the child to see the voice and comment on normal or high pitch like a normal child, mature female estrogen exposure or a deep male androgen effects. Then like in all short cases you look at the general look, whether the child is sick looking, well looking, is there any cyanosis or respiratory distress at rest, is there any pallor or jaundice, what is the nutritional status of the child, and is there any diagnostic or dysmorphic features, what are the distribution of facial hairs, what is the body habitus, and what is the muscular growth of the child, is there more muscles, more fat. Followed by the anthropometry, you do the measurements, check the height, arm span, upper segment, then upper segment and lower segment ratio. Then you remember, when you are doing this, keep a small card with you and write it, because in the heat of the short case sometimes you forget it. Then you check the weight increase in the Cushing syndrome and hypothyroid, and FOC, which is increased in case of hydrocephalus and raised intracranial pressure. So you may have all come across the Cushing-eyed child, which can be many causes, but these are the general features. So then you go for the maneuvers. First from the front, you check the child with the arms straight, then you tell the child to close the arms, make fist, then touch shoulders to see achondroplasia. Then you check from the sides, arm on the side to see the short or long limbs. Then from the back, tell the child to touch toes for kyphus scoliosis, and then sit instead up for proximal myopathy, which in case of Cushingoid due to steroids. Then you go start from the hands, check the pulse for bradycardia, which is present in raised intracranial pressure, respiratory rate and temperature. Then in the arm, check the blood pressure. Hypertension will be present in 11-hydroxylase deficiency. Then in the face, you check the eyes for movement for a palsy. If there is any facial or eye palsy, then you go and check in detail. If you have no time, then tell at the end that you want to do it. Then the mouth, you check for the oral ulcers or thrush. Then the chest, do the Tanner staging in girls, but you ask the permission of the examiners. Then in abdomen, do for the check for the abdominal mass like hepatoblastoma, ovarian and a renal tumor, pubic hairs, external genitalia in boys, Tanner staging, and take stretch penile length after asking for permission. So I repeatedly ask you that you must take consideration of the modesty of the child. Then testicular volume, you can ask for orchidometer, or if you can do it, you can take it with you. Lower limbs for the tone, bulk, power and reflexes. Reflexes, delayed release phenomena in hypothyroid. Then gait for the long tract signs. I have made a hypothetical description. You can make your own descriptions, but do practice this. So I have just examined 6-year-old Junaid Khan, who was conscious and cooperative during my examination. He is thin, lean, well-looking child. There was no respiratory distress or cyanosis at rest, no pallor or jaundice. He has a deep voice like adult male with excessive facial hairs in male pattern without any dysmorphic features. His height is 120 cm, arm span of 121 cm, upper segment of 60 cm, where the upper segment to lower segment ratio is 1. There is no asymmetry and FOC of 50 cm. His pulse is 90 per minute, respiratory rate of 19 per minute, and is afebrile to touch with a BP of 140 by 90 millimeter of mercury. The tenor staging of puberty development is stage 3. The examination of the back and abdomen was normal. There was no cutaneous stigmata of neurofibromatosis, McCune Albright, and all accessible cranial nerves are intact. There was no focal neurological defect. I want to plot height, weight, and FOC on centile charts and do fundoscopy. So, what are the investigations for precocious puberty? FSH to LH ratio is low in prepubertal. Gonadotropin releasing hormone stimulation, luteinizing hormone should be less than 5 international unit per liter. Bone age is advanced in central precocious puberty. Estradiol or testosterone levels, dihydroepiandrosterone or 17-hydroxyprogesterone. Skeletal survey for polyostotic fibrous dysplasia for McCune Albright syndrome. Imaging in ultrasonography and CECT abdomen or CT-MRI brain. So what are the indications of imaging? Imaging should be performed in all males with a precocious puberty and in females who are less than 6 years and rapid breast enlargement and greater than 30 picogram per ml of estradiol. So this is the tenor staging of the female in prepubertal. Then there is a breast bud, then breast elevation, areolar mound, and adult contour. And this is the tenor staging of the male. So you must memorize these tenor staging and remember the sequence. So the treatment of precocious puberty is you give leopride acetate 0.25 to 0.3 mg per kg, minimum of 7.5 mg intramuscular every 4 weeks. If the child is less than 25 kg, you give 7.5 mg intramuscular monthly. Between the 25 to 37.5 kg, give 11 to 25 mg intramuscular monthly. Whereas in a child greater than 37 kilogram, you give 15 mg intramuscularly monthly. Tenor staging of breast 2 to 3 can regress, but not 3 to 5. The amount of glandular tissue decreases, menses cease, pubic hair remains stable, but progression slows. So there is a decrease in uterine and ovarian size. In boys, the testicular size regresses. There is a variable regression in pubic hair and decrease in frequency of erections. If treatment is effective, testosterone should be decreased to prepubertal levels less than 10 to 20 nanogram per deciliter and estrogen less than 5 to 10 picogram per ml, whereas luteinizing hormone should be less than 1 international unit per deciliter. Menarche and ovulatory cycles start about an average of 18 months, 16 to 24 months after cessation of therapy. So you must remember this. So growth hormone along with gonadotropin releasing hormone analog can be used to address short stature. So what is the precocious puberty? If this development of secondary sexual characters before 8 years in girls and before 9 years in boys. 90% of girls have idiopathic, whereas 75% boys have a CNS cause. The female sequence is mnemonic BPM. First is the breast, then is the pubic hair, and then is the menarche. Whereas the male sequence is initially the testicular growth, followed by the pubic hair, then axillary hair. In pseudo-precocious puberty, testicular size is normal. So the causes in central, the idiopathic causes, the CNS causes such as the brain tumor, hydrocephalus, hypothalamic hematoma, meningomyelocele, severe head trauma, prolonged and untreated hypothyroidism. Both central and precocious occurs in treated congenital adrenal hyperplasia, McCune Albright, and in familial male precocious puberty. While as in peripheral, in girls there is isosexual. So McCune Albright, ovarian tumors or cysts, granulosa thecal cell tumor, adrenal tumor, they are the feminizing tumor, and exogenous estrogens. And hetero occurs in the girls due to congenital adrenal hyperplasia, adrenal ovarian tumor, glucocorticoid receptor defect, exogenous androgens. Whereas in boys, the isosexual means the boy will have advanced male characteristics. Congenital adrenal hyperplasia, Leydig cell tumors, HCG secreting tumor, CNS tumor, hepatoblastoma, mediastinal tumor, Klinefelter teratoma, glucocorticoid receptor, and heterosexual adrenal tumor that are feminizing. So male will present with a female-like habitus and exogenous estrogen. So this is a picture of the McCune Albright syndrome. look the cutaneous manifestations of McCune-Albright syndrome. So thank you very much for your listening, and I hope this will help you out. This is basic guidelines. The aim of short case is that you have to identify all the available findings and you should proceed in a short case in a sequential manner. So I will be looking forward for your feedback. May Allah be our helper, protector and guide. Allah Hafiz.